Thank you. And then it's, oh, I'm live. You're on. Good evening. Okay. Okay. Good evening. Good evening. Am I loud enough? No. Do I need to use this mic? Oh no. That kind of sucks.
Okay, guys, we're ready to get started.
All right. Good evening, and thank you for attending the June meeting of the Southeast Chapter of the Society of Critical Care Medicine. My name is Kathleen Chester, and I am president for the chapter, and I welcome you. As you know, we always start our meetings off with reading our mission, and our mission is to secure the highest quality care for all critically ill and injured patients through a multidisciplinary approach and at a regional level. With that being said, I also want to thank our exhibitors. We have Janssen, Pfizer, Otsuka, Lifelink, and Activists who are here tonight, as well as in Memphis. I want to thank our Memphis participants for joining remotely, anyone who's participating remotely on your own, and then also those participating in Birmingham for the first time. We're really excited to have them as a remote site as well. A couple of announcements before we get started. We are offering CE credits for pharmacists, nurses, dietitians, and physicians. So please make sure that you signed the appropriate sign-in sheet, and then make sure you got the evaluation. If you're a pharmacist, make sure you picked up the pre and post test. All of that will need to be turned into us at the end of the presentation. And for all disciplines besides pharmacy, you will get your certificate before leaving tonight. If you're a pharmacist, your certificate will be mailed to you. For the Atlanta and Memphis locations, we do have raffle tickets, which are the index cards for visiting with the different exhibitors. So please make sure if you completed that to turn it into the back of the room, and we'll be doing the raffle at the end of the presentation. I want to make sure that everyone's aware of our Spike Out Sepsis Atlanta event. So anyone is welcome to participate. This is a 6-on-6 volleyball tournament, and this is our second year doing this. It's going to be September 19th, and we had a really great turnout last year, and I anticipate an even bigger turnout this year coming up. If you're interested, you don't need to be a professional volleyball player to participate. Amateurs are welcome. We take a really fun and unique spin on it, so I hope that you guys will consider forming a team at your institution and participating this year. Finally, we have membership forms available. So if you're not a member, we welcome you to consider joining. In training members, so that's residents, students, and fellows, receive complimentary membership for the year. And then anyone else would be a $45 fee for the year. So we encourage you to join. If you are a member already and you're thinking about getting more involved, or you have a particular interest in leadership, we welcome you to talk to one of our committee chairs or executive officers this evening, and we'll be happy to talk to you more about some opportunities we have available. So without further ado, tonight we're going to shed some light on the topic of organ donation, and we are honored to have keynote speaker Dr. Anu Subramanian here with us this evening. Dr. Subramanian is medical director for the surgical ICU at Grady Memorial Hospital, and she holds faculty and clinical appointments as assistant professor of surgery and attending surgeon for the Emory University School of Medicine Department of Surgery. Dr. Subramanian also serves as associate program director for the Emory University School of Medicine's Trauma Critical Care Fellowship. She has extensive experience in surgical critical care through her clinical work, her publications, and her research contributions. In addition, she serves on numerous committees at the institutional, regional, national, and even the international level. At this time, it is my pleasure to welcome Dr. Anu Subramanian, who will be presenting critical care aspects of organ donation.
Thanks. Okay. All right. Good evening. Can everyone hear me without this? Okay. Oh, for the webinar. Sorry. Okay. Well, let me just. Okay. So good evening, and I'm going to talk a little bit about the critical care aspects of organ donation. I was actually asked by LifeLink. I was invited to be the speaker. And I don't, it's not moving. Do I do it this way? There you go. Okay, thanks. All right, so first of all, what is LifeLink? LifeLink is an organ procurement organization. They're not-for-profit, and they provide the link between potential donors and patients that are awaiting transplants. They serve a federally designated area, and there are 58 organ procurement organizations throughout the United States, and they're certified and regulated by the Center for Medicare and Medicaid Services. Right above them is UNOS. So UNOS stands for the United Network for Organ Sharing, and they came about in the 1980s, and that's where all the transplant centers and all the organ procurement organizations are all under the umbrella of UNOS. Okay.
Just one of the 80 slides. I'm sorry, Annie. It's seeing something different.
Go back one. Okay.
Good.
Yep.
All right, thank you so much.
UNOS came about in the 1980s. They're a federal contract regulatory agency, and all the donors and recipients are registered through UNOS. UNOS maintains a centralized computer network which links all the organ procurement organizations and transplant centers to facilitate allocations of organs to recipients around the country based on their geographic locations, time that they've been waiting on the transplant list, the severity of their illness, ABO and HLA matches, the size matches, and the age of the patient. These are our local transplant centers. We have Emory University Hospital, we have the Children's Hospital of Atlanta, Piedmont Hospital, and then Medical College of Georgia, which is in Augusta. In 1998, the Center for Medicare and Medicaid Services actually made it mandatory for hospitals to report all deaths to them. They also felt that donation should be offered to all families, and only trained, designated people should be able to approach families about organ donation. And mortality charts are actually reviewed by OPOs. So LifeLink is essentially exempt from HIPAA. So their charts are open to LifeLink for review as part of their review. Now the question is when to call LifeLink. So how do we start the process of getting LifeLink involved for organ donation? The key thing is to make sure it's timely. We try to get them involved even as early as when the patients hit the emergency room. Most often, though, it's in the ICU. They also should be notified within 1 hour of cardiac death, because you can also receive procurement of tissue samples for after death, and also when a family member asks about organ donation. Some clinical triggers that organ procurement organizations like providers to know about, because that kind of gives them the idea of when to get early involvement of your organ procurement organization. When patients are intubated with a coma, a massive stroke, suffered a hypoxic insult, have a massive brain tumor, cerebral injury, near drowning, cerebral edema, or even cerebral hemorrhage. So any of those findings, along with a Glasgow Coma Scale of less than or equal to 5 when they're not sedated, unresponsive or posturing, no cough or gag reflex, no spontaneous respirations, or a discussion is actually going to be had with the family about DNR and withdrawal of support. So why is organ procurement, other than the thousands of people on the wait list for organs, hospitals are actually held accountable for the number of patients that are organ donors. So this is our report card at Grady. And this is from, I think, 2 years ago. I haven't received last year's yet. But there's something called a organ donor conversion rate. And these are the numbers of actual donors over the number of eligible donors. And CMS sets these standards. And the number that they set for hospitals is greater than or equal to 75%. And here our number is about 64%. So hospitals are set to a standard to work in partnership with organ procurement organizations so we can meet these standards. So one thing when I started my job over at Grady, when I saw this metric, I was like, well, what can I do in my position to help improve this and help hit not only be part of the greater good of organ donation, but also help my hospital, my institution, reach a metric. I went back through and looked at our old brain death policy and how do we declare people brain dead at our institution. Our old policy, which is from the 1990s, required 2 clinical brain death exams 6 hours apart, and you can see it was kind of stringent about actually who can perform these exams. One of them has to be done by either a chief resident, a neurosurgeon, a neurology resident. I mean, there were all these parameters to have to meet to be able to pronounce someone dead. And on top of that, you need 2 exams that have to be 6 hours apart. So looking at our old policy, when I looked at the data, it took an average of 17 hours to pronounce someone brain dead at Grady. And we also have this poor organ donor conversion rate. So what kind of things can we do to fix that? Looking through the literature, the American Association of Neurology published in 2010 some guidelines. They actually initially, in 1995, had an initial set of guidelines, and they updated them in 2010. And in their new set of guidelines, they stated that in adults, the recovery of neurologic function wasn't reported when the criteria used in their publication from 1995. So basically, using the criteria they published in 1995, no one recovered from brain death. So they therefore supported the use of only 1 neurologic exam in the diagnosis of brain death. And they even provided a checklist for this determination. Another study from New York looked at almost 1,300 patients that were declared brain dead. They too found that no patient that was declared brain dead after 1 exam, upon an exam, was actually found to recover any brainstem functions on their repeat exam. And their mean time was 19 hours. Looking deeper into their data, they found that there was a 26% reduction in brain death exam frequency on weekends. Okay, so when you have 2 exams that span through a Saturday or a Sunday or a Friday night to a Saturday, most of you guys know that the hospital is more kind of working on a skeleton crew on weekends. The consent for organ donation decreased from 57% to 45% as that interval time increased, and the refusal of organ donation increased as that interval increased. So the bottom line is the longer these patients' families had to wait, or longer than the patients had to wait and be unstable. Either their organs were no longer good enough for procurement, or the family was just tired and fatigued and were done and didn't want to donate. So they too concluded that a single brain death exam should suffice. Right around the time when I was working on this, there were these two big stories that were in the headlines. I'm sure some of you might recognize the pictures. So one was the 10 or 12, 13-year-old who was undergoing her tonsillectomy and post-op, and she had a cardiac arrest and suffered an anoxic brain injury. And the other was a pregnant mom who suffered a massive PE and also suffered an anoxic brain injury. And both of them were eventually diagnosed as brain dead. But clearly the topic of brain death in such a short period of time was highlighted in the public eye. And I really felt like as providers in a hospital that we needed to know what we were talking about and make sure that we were doing this expeditiously and without delay. So we came up with a new brain death policy. We created a multidisciplinary team, and we came up with a policy that stated you only need one clinical brain death exam with an apnea test. Everyone who was performing this single exam was credentialed by the hospital. And we also were very fortunate to have a very busy and very involved neuro ICU team that, in my opinion, are experts when it comes to the brain. And they were involved when we were, for whatever reason, unable to perform an adequate clinical brain death exam. For example, someone's eyes were swollen shut from their trauma and you couldn't look at their pupils. And also in patients who were unable to tolerate an apnea test. Patients who were underage, like 15 to 17, which are considered pediatric, at least in neurology literature, we maintained two clinical brain death exams that were actually 12 hours apart by two different credentialed faculty or fellows. And we borrowed the policy from CHOA for this. And the reason why in pediatrics is different is the AAN, or the Association of from American Neurology, all their studies were only done in adults. So that really hasn't been extrapolated to children, and something as important and declaring someone brain dead, I think the safest thing to do is to just wait and do two clinical exams. Things that you need before you move on to declare someone brain dead. You need to have a clinical or some kind of neurologic imaging that shows evidence of some kind of catastrophe that would give someone the physical exam that you are seeing. They should have normal serum electrolytes, in particular the sodium, potassium, and glucose. They should have a normal serum pH, an appropriate length of time off of sedatives, a core temperature greater than or equal to 36. They should be hemodynamically stable on a stable amount of pressors, so they don't have to be completely off pressors, but as long as they're on a stable number of pressors. And everyone should have a urine toxicology screen to make sure that there is nothing in their urine that might cause the symptoms of brain death. The parts of clinical brain death exam, this is what we go through. This is what we're all credentialed to do. First thing is the response to verbal stimuli. That patient should not have that. Their pupils should be non-reactive to light, and that's what we call they're fixed and dilated. They have absence of corneal reflexes. They have no oculocephalic reflex, no oculovestibular reflex, and they won't have any gag or cough reflex, and any response to painful stimuli would be absent. So not only do we perform a clinical brain death exam, but everyone also must get an apnea test as long as they can tolerate it. So one of the cardinal signs and essential components for the clinical determination of brain death is apnea. When you have loss of brainstem functions, you lose the centrally controlled breathing function, and that leads to apnea. So that has to be a component of brain death, is apnea. So the way we perform an apnea test, all patients are pre-oxygenated. You want a goal PCO2 between 35 to 45. So you want to make sure their tidal volume and their respiratory rate can give you that PCO2 of 35 or 45. You then disconnect them from the ventilator, and you have the respiratory therapist still put them on a high flow oxygen. A lot of times they'll put a catheter down their ET tube and hook it up to oxygen, so you still have oxygen going through their lungs, because you don't want them to desaturate during the test, because that kind of ruins the test. Once they desaturate, then their heart rate drops, their blood pressure drops, and then they're too unstable to complete the exam. While for this period of time, it's usually about 10 minutes, you watch the patient closely for signs of any kind of respiratory effort. I usually hang a liter of fluid and have it going in just to prevent hypotension during the exam. And you draw an ABG at 10 minutes. If the PCO2 increases greater than or equal to 60, or an increase greater than or equal to 20 from the initial ABG, then that's consistent with brain death. If a patient does not meet those criteria, you start all over. You put them back on the ventilator, check another baseline ABG, and you move forward. And there's always a possibility, if the patient does not meet those criteria, it's possible they had a spontaneous breath somewhere and that they're not clinically brain dead. Moving on to ancillary tests. In cases where patients are too unstable for an apnea test, or for patients who you can't complete a full clinical brain death exam because, like I mentioned earlier, their eyelids are swollen shut, so you can't look at their pupils, it's a good idea to perform an ancillary study just so you can be 100% sure. Ancillary studies measure the clinical state of cerebral circulatory arrest, and that's closely related to the clinical determination of brain death. So it should never supersede a clinical exam. Everyone still needs a clinical exam, but it might give you a little bit extra information to feel comfortable enough to pronounce someone brain dead. It should never be performed on patients who don't meet some, if not all, the neurologic criteria of brain death. And unfortunately, because these studies are performed by a practitioner and also interpreted by a provider, there's always going to be some false positives and false negatives. These are the validated options for ancillary tests. So we have cerebral angiography, transcranial Dopplers or TCDs, EEGs, and nuclear blood flow scans. Starting with cerebral angiography, about 20 years ago, this was the gold standard for probably longer than 20 years, or maybe 30 years ago. This was the gold standard for diagnosis of brain death. It's also the most invasive. Okay, so you cannulate the artery in the arm or the leg, you travel up to the carotids, and then you inject contrast. And then you look to see if there's a flow in the intracranial vessels. If there is no flow, that's diagnostic of brain death. Something that's come into more in favor is transcranial Dopplers. It's quick. It's done at the bedside, so patients don't need to be transported to radiology or another suite. And you can get the information right then and there. And it's painless for the patient. It's non-invasive. The only limitation is both the operator, the technician that performs it, and also patient anatomy. The probe, and another thing is approximately 10 to 20% of the patients will not have an adequate bone window for where the ultrasound can actually pick up the vessels. However, when it can be obtained, the specificity is very good, the sensitivity is very good. One thing a lot of these brain injured patients is if they've had a prior craniotomy, it may not be accurate. So to perform, you can put the ultrasound probe right at the temporal bone, and what you're looking for are reverberations of flow. And if they're absent, that's consistent with brain death. Another option is to go through the orbital window if for whatever reason you can't obtain good views from the temporal bone. So one of the oldest forms is EEG. But the problem with EEG, it's not, there can be a lot of false positives because there are other things that can give you diminished waves on the EEG, different sedatives, hypothermia. So it's not as definitive as some of the others. Another one is nuclear blood flow scan. This is pretty classic. Patients receive a radioactive isotope through their veins, and as it circulates, multiple pictures are taken by a gamma camera. And when you have no, they call it a hollow skull sign or a light bulb sign, so when you have no flow in the brain, that's consistent with brain death. The Society of Nuclear Medicine in 2003 actually published their guidelines for using this for the diagnosis of brain death. Other possible options that are not invasive and that we usually get a lot of are MRAs and CTAs. However, neither one of these studies have been validated for the diagnosis of brain death, and the reason why is because patients who are this sick have variations in their cardiac output, and as you inject arterial contrast that goes through to the brain, you are not going to get good pictures. Someone with variations, and to do something as critical as diagnosing brain death by imaging, you really want it to be right. Now, there are two types of organ donors. We're all very familiar with the donation after brain death. So the donation after death by neurologic criteria. But there's also something called the donation after circulatory death. We abbreviate it often as DCD. So these are patients who have a non-survivable injury or non-survivable state. And their organs are removed after withdrawal of support. Again, based on irreversible cessation of circulatory function. And these family has withdrawn care still would like their loved one to be an organ donor. So who are these patients? These are patients who present with severe neurologic injuries, either a traumatic brain injury, intracranial hemorrhages, strokes, or anoxia after a cardiac arrest, for example. Another gamut of patients would be patients without significant neurological injury. For example, significant degenerative neuromuscular disease like ALS. End-stage cardiopulmonary patients and end-stage heart failure who are hooked up to machines dependent on dialysis or vent support, and also high spinal cord injuries. So one, they should not meet the criteria for brain death, and number two, they should have no chance of survival off the ventilator. So this is our process for DCD. It can be pretty dramatic, and the providers that are involved in the process is all voluntary. To watch someone lose their vitals, it can be pretty traumatic. It's only a voluntary basis. So a patient, after the family has agreed to this, the patient is taken to either the operating room if the family does not want to be with the patient during the process, or they're taken to our pre-op holding area if the family chooses to be with the patient during the process. During that time, the patient is extubated, and all support, like vasopressors, fluids, are all withdrawn. And we wait there until the patient loses a pulse, and then the patient is whisked off to the operating room, and we wait there for approximately 5 minutes to make sure there are no signs of spontaneous respiration and no regaining of pulse. Once that 5 minutes has arrived, the patient is pronounced dead. The team who's involved in that process leaves the operating room, and the transplant team, who's already dressed and ready right outside the door, they come in and they take over in the transplant process. So again, it's pretty dramatic. With DCD, a patient has to lose their vitals within 45 minutes. You can only procure kidneys and liver on DCD because that warm ischemia time is too long to get hearts and lungs. So we usually keep that time of 30 to 45 minutes. So I wanted to briefly talk about brain death physiology as we get into how to manage some of these patients in the ICU as they're going through the process of either herniation or maybe have already been declared brain dead as we get them ready for organ procurement. So what happens when someone is going through the process of brain herniation or brain death? There's something called a neurogenic cardiac injury. Patients get this massive catecholamine release, and they often get hypertensive, they get very tachycardic, but believe it or not, they all have fairly normal coronaries, and this effect that has on the heart, even though they might have elevated troponins, will all go back to normal. They also can get neurogenic pulmonary edema. So because of this catecholamine surge, they have rises in their blood pressure and their systemic vascular resistance, and fluid shifts from a high resistant systemic circulation into a lower resistant pulmonary circulation, and then they start getting this pulmonary edema. There's also an endocrine factor. Because of all the stuff going on in the brain, it affects the thyroid levels, cortisol levels, you have vasopressin issues, and that's why you have diabetes insipidus. And diabetes insipidus actually can cause decrease in cardiac contractility because you're low on the vasopressin. With the knowledge of what goes on during herniation and brain death, a lot of places have done studies looking at what we can do to support the heart and the rest of the body during this process, so we can support some of those organs. This group looked at 133 donors. They had 64 in their control group, and the other two groups received steroids, and the other group received steroids plus levothyroxine. And what their studies showed that patients who received the steroids and levothyroxine had a statistically significant decrease in the number of vasopressor requirements. Okay, so vasopressors, if you have increase in vasopressors in some of these patients, it actually affects end organs, right? So it will affect your kidneys, it will affect your liver, it will affect your heart. So the fact that you can decrease the use of those vasopressors might be a good thing. Also in their patients, although not statistically significant, with the use of steroids and levothyroxine, they actually had a slightly higher number of organs that were able to be procured. This is a group out of Arizona, a trauma critical care group that looked at early versus late use of levothyroxine in organ donation. And early was considered before the patients were declared brain dead, and late was considered after they were declared brain dead. So they had 100 donors, about 77, this was a retrospective review, 77 received levothyroxine, 37 received it before the patients were declared brain dead, and 40 received it after the patients were declared brain dead. Busy slide, but key things were patients who received the levothyroxine early required less volume. They had less doses and duration of dopamine infusion and less doses and infusion of vasopressin infusion. So again, less fluid requirements and less pressor requirements. They also noted an increase in the number and percentage of organs that were procured. And on multivariate linear regression, the two things that were associated with an increased number of solid organs that were able to be utilized were the use of blood products and the early use of levothyroxine. Lung transplantation is for institutions that are able to provide lungs for the donation, for the organ donation pool, are actually felt to be pretty strong in their organ donation process. Lungs are very, very difficult to manage. We're a level 1 trauma center. We love giving fluid. A lot of these patients come with pulmonary contusions, and because of that, a lot of times lungs cannot be used. But really, I think a sign of a really good program that has a good relationship with our organ procurement organization, getting lungs, I think, is a good thing. You can see only about 16% of organ donors receive lungs. So it's not a lot that go into the pool. And again, for multiple reasons, the acute lung injury after brain death, pneumonia, aspiration, I already mentioned pulmonary contusion, atelectasis, and many potential usable lungs are actually excluded based on the current standard criteria. The program out of San Antonio, SALT stands for San Antonio Lung Transplant Protocol, they really partnered with their organ procurement organization and essentially looked at every organ donor as a potential lung donor. And they went to look and see, well, what we can do for every single one of these patients to try to get them to a point where they can be a lung donor. So they did many active things. They did alveolar recruitments for patients with PF ratios less than 300 and a chest x-ray that revealed infiltrates. They used high inspiratory pressures on pressure control ventilation, and they deemed it a success if they saw improvement in their PF ratio. They also assessed fluid balance pretty rigorously. They minimized crystalloid and diuresed the patient to negative fluid balance. They maintained the head of the bed up to about 30 degrees to decrease the incidence of aspiration. And they also made sure that they checked pressures in the ET tube balloon, again, to prevent aspiration events. Based on their protocol, they were able to statistically significantly increase their organ donor rate for lungs. So what are things that we can do to help improve our organ donor pool? LifeLink came up with something called a catastrophic brain injury guidelines, and it's to be utilized to address the predictable consequences of brain death, like I mentioned. All those brain death physiology, the heart, the lungs, the diminished endocrine function. We know this is going to happen, and this is a way that we can maybe nip it in the bud. It helps preserve organ function and the option for donation for that family. And it should be utilized when further active therapies are determined to be futile. So in the trauma bay, when neurosurgery states that this patient has a non-survivable brain injury, you can start it in the trauma bay. Or in the SICU in someone who has already blown their pupils and you're just waiting for them to lose their cough or their gag. Or even after we determine brain death. This is LifeLink's guidelines. We actually have an order set in our electronic medical record, which we use. And I kind of wanted to go through a case so you can see just the kind of schematic of how to start it, when to start it, and what we actually see in the process to when a patient's actually pronounced. So this is a 24-year-old male who suffered a motor vehicle collision with ejection. He had a Glasgow Coma Scale score of 5 on arrival, and he was posturing. His pupils at that time were 3 millimeters bilaterally, and he was intubated in the emergency department. His CAT scan showed a massive intracranial hemorrhage with shift and already with signs of herniation. And neurosurgery deemed this a non-survivable brain injury. So he was taken to our ICU, and I can't see this on my screen. I have to come over here. Oops. So you can see here his temperature, 35.1. He's breathing 20 times a minute, heart rate 120, slightly hypotensive, blood pressure 100/60. His pupils were about the same, and he had a gag reflex and a cough reflex. He was breathing about 20 breaths per minute on a set rate on the ventilator of 12. And here was his blood gas, 7.35, 30, 105, and saturating 100%. He was getting normal saline at 100 cc's an hour, making about 50 cc's an hour of urine. And his potassium looks like was 3, glucose was 110, I think, hemoglobin 10, and INR is 1.5. So active things to do. I mean, this guy has a non-survivable brain injury. As family is coming to grips with all this, there are things that we can do to support the patient and support his organs. So we try to get the patient up to 36, warm fluids, bear hugger to warm them up. The patient still has a cough and gag, so they're still alive. We do still want to treat them with some fentanyl and propofol so they don't feel any pain. Still continuing to check neuro checks every hour, especially looking at pupils. So we really try to educate the nurses because usually it's the pupils that are the first neurologic sign to go. And go ahead and replace the potassium and give some FFP since the patient is bleeding. We like their INR to be on the lower side. And at this time, this is someone with a non-survivable brain injury, so lifelink should be notified. So 8 hours later, patient's temperature is now up to 35.7, a little more tachycardic now and hypotensive. Pupils, the right pupil has blown. So right pupil is now 6 millimeters and non-reactive, but the patient still has a gag and a cough. Still breathing over the ventilator. PCO2 is about 30. Getting fluids. Starting to make 300 cc's an hour of very dilute urine. And sodium is starting to creep up at 147. So this hypotension, this brisk urine output of very dilute urine, the elevated sodium is starting to get us to think about DI. Okay, so continue to warm the patient. We'll continue the fentanyl drip, hold the propofol since the patient's hypotensive, continue to check pupils. We'll change the patient to D5W since the sodium is starting to rise and start the monodopamine drip for hypotension, and also start vasopressin or DD-AVP since we assume they're going into DI. And hopefully this will help decrease their urine output and concentrate their urine. Hemoglobin's 8, so we'll continue to replace the potassium and give 2 units of blood. 6 hours later, so we now have a temperature of 36. Blood pressure is better, heart rate's better. Now the patient has blown both pupils. Right? Now they have no gag, no cough, and no response to noxious stimuli. Still breathing a little over the vent at 16 breaths a minute on our rate set at 12. PCO2 is 32. Now getting D5W, 20 of dopamine and some vasopressin. Urine output has appropriately responded. It was 300 an hour, now it's down to 70 an hour. And creatinine's up to 1.4. Hemoglobin's 10, INR is 1.2. So another 6 hours later, we continue to maintain, same 6 hours, we continue to maintain our temperature greater than 36. So one thing that happens with the ventilator, especially in these young people, their heart beats so fast that sometimes the ventilator senses that and it triggers the vent to give them a breath. So you need to decrease the sensitivity on the ventilator. And this is where, since we know he's starting to blow his pupils, requiring high amounts of dopamine, this is when we can start the levothyroxine and the steroids. Okay, we're starting pressors, patients blown their pupils, this is impending brain death. So we go ahead and start levothyroxine and steroids and insulin for an elevated sugar. So now that you've decreased the ventilator sensitivity, no longer breathing over the ventilator, with the levothyroxine and the steroids, you're able to come down a little bit on the dopamine. So this is the time when I'd notify the family and lifelink, and you prepare the patient and the family for a clinical brain death exam and an apnea test. So in the next 20 minutes, you would perform your clinical brain death exam, perform an apnea test, you notify the family of the results of those, and then you introduce the family to lifelink, and lifelink can take over the care of the patient. So no, this is 20 minutes from the initial clinical exam to the time when the patient's declared, compared to the usual 17 hours that we were dealing with before. So one group we just can't forget are the families. They have gone through a grueling process. These are traumatic events for them. Their loved one was well, and next thing you know that they're in an ICU and we're talking about them dying. So by the time this has come around, whether it's a period of hours, it could be 24 hours or maybe a little longer or less, but they're physically, mentally, and emotionally exhausted. And some want to be actually in the room to witness a clinical brain death exam and an apnea test. And the most important thing is to keep them updated so there's no distrust between the clinical team and them. We really try not to use terms like their loved ones on life support or talk to them about withdrawing, because as far as they're concerned, even though they're declared brain dead, those patients still have a heartbeat and they have a blood pressure. So when you talk to them about life support, that means they're on a support that's keeping them alive, but in a sense, they're actually brain dead. We always offer social services, chaplaincy services, and have palliative care. And the key thing is, as providers, you don't want to bring up organ donation. It removes the distrust on the part of the family that the patient's physician or provider may actually have a vested interest in organ donation. And a lot of studies have supported that this decoupling of the physician and then the person that actually goes and talks to family about organ donation actually is shown to increase the consent rates for organ donation. So after brain death declaration, it's our policy that if the family does not want to donate, we allow them to have up to 24 hours to have other family members come in to say their goodbyes before we disconnect them from all the machines. But if the family agrees to the donation, we as the ICU team help lifelink out in whatever procedures they need. Sometimes they need central lines, arterial lines, they need bronchoscopy. So we go ahead and do all that stuff for them just to help them out for the greater good of organ donation. So in conclusion, just some take-home points is we just want to focus on early notification of lifelink and for those clinical triggers. Anticipate the clinical derangements of the patient, so in their respiratory, cardiac, metabolic, and endocrine. And try to create and utilize protocols that will protect the patient so the family can have an option of organ donation. And they may not donate, but at least it will keep the organs well enough, keep the patient alive long enough so the family has the option if they want to donate or not. And there's always the option of donation after cardiac death. Try to perform a timely determination of brain death. It's better for the patient who's going to be donating organs, and it's also better for the family. They're exhausted, they get fatigued, and there may come a point where they're like, you know what, I'm spent, I don't want to do this anymore, I just want to leave this hospital, I just want to leave it and just let them go. And anticipate and support any family needs, and that's why continuously updating the families and getting a sense of where they're at in the whole process can be very helpful as you move forward. So thank you. Does anyone have any questions? Yes.
On whose role is it typically to contact Lifelink first?
Okay, so the question was, whose role is it to contact Lifelink first? It actually can be anybody. It can be a nurse, it can be a tech, it can be a physician, it can be the secretary. It can be anybody to call LifeLink. Yes.
I'm sorry if I missed it, but what's the typical time frame once the LifeLink takes over from the time where the organs are going to be harvested or direction?
Yeah. So the question was how long it takes from when LifeLink takes over to when organs are. And the term is procured. We use the term procured. It can be anywhere from 24 to 48 hours. LifeLink, the whole process actually is pretty amazing because the organization has to first determine if there's a match. So they actually go and harvest, or I guess it's a harvest because you're harvesting lymph nodes. They just take lymph nodes from the groin, and those get sent to a lab so you can get blood type, and you get all the HLA from lymph node type for types. And those go to UNOS, and then you start figuring out if there's a match for the patient and where it is. And usually that patient, wherever they are, usually gets notified around that time. And so then LifeLink has to do all these studies. We usually get an echo to see how good the heart is. We'll bronch them for the patient, so for the organization, so we can make sure there's no tumors, there's not a pneumonia, and we also can try to help expand the lungs by bronchoscopy. The LifeLink also has to give the operating room at that institution enough time to prepare a team to stay for that. So that goes on the books a good 24 hours in advance, because also you have a transplant team that's coming from wherever in the southeast or in the country to come and to retrieve the organ. So it's a big process with a lot of moving parts, but it's pretty amazing to be part of it. So yes.
Do patients get tested for HIV and Hep C and all the other?
Yes, that's a good question. The question was, do patients get tested for HIV and Hep C? Yes, they do. And yes, that can definitely make them not a donor anymore, depending on the organs. And they also biopsy organs. So they'll have interventional radiology come in and biopsy organs to see burden, if maybe they're worried about a tumor or for viral burden. So sometimes they will come in and do biopsies to see if the organs are well enough as well. Yes.
I'm not as familiar with the actual criteria for them accepting the organ. But are there any medications that would preclude someone, like if they had gotten a certain medication that would preclude them from being able to donate?
So the question is of whether there's any medications that would preclude a patient from being an organ donor. And are you talking about a medication like given in an ICU setting?
I'm not aware of that.
I don't think so. I haven't come across a case that's like that. I don't think so. Yes.
Are you obligated, if you have someone, let's say, who has HIV, are you obligated to report them to LifeLink so they can say they're not acceptable as organ donors, or can you automatically make that decision?
No. So the question was, if we know as providers that the patient is HIV, are we obligated, or can we tell LifeLink?
Do you just not even offer LifeLink at all, or do you have to have LifeLink say that they're not?
Correct. So remember the regulations by CMS is all patients have to go through LifeLink. So it has to go through LifeLink, and LifeLink is the one that says yes or no. Yeah, it has to go through LifeLink, and that's by law. Believe it or not, it's by law.
Is there ever a time, like on a driver's license, you can have it notated that you want to be an organ donor? How often is that like a useful piece of information versus a family making a decision?
So that's a good question, and I don't know. So the question was, is if stating on your driver's license if you're an organ donor, does that supersede a family decision, or what's worth more? And I don't know if this is by state or not, but I know in the state of Georgia, you have to be registered through the state to be an organ donor, and having it on your driver's license is not good enough. If you are in the state by the state registry as being an organ donor, you will be donating your organs. If it says it on your driver's license and your family chooses not to make you an organ donor, the family's wishes are honored. So if you want to be an organ donor, you need to get your name on the state registry. So we've had that issues before. We had to get ethics involved, and but it's the family's wishes, actually, in those cases. Any other questions? Okay, thank you.
All right. At this time, I want to thank the Memphis and Birmingham locations for participating with us, and we wish you a very good evening. I'd like to ask the Atlanta folks to stick around for just a second so we can complete our raffle. So we usually have our speaker to do that. Yep.
Dina?